We are also recruiting patients for the Unicure trial. We have the only patients so far who have been accepted and have passed the screening for the next cohort of individuals in the United States. And we're hoping to screen additional patients this fall. As well, we are very interested in seeing individuals who are younger with Huntington, less than the age of 50, who may qualify for the ASO Generation 2 trial. And that's what I've got written right here. So please feel free to ask us questions about these very promising gene therapies. I'm going to speak predominantly about non-gene therapies in Huntington's disease now. And I'm going to first start with the Annexon trial, which is a very interesting, unique study that we conducted in phase 2 this past year. And what we do know is that there is significant evidence of the immune system playing a role in the progression of different neurodegenerative diseases, including Huntington's disease. One component of the immune system is called the complement system. Now, to activate the complement system, which results in a cascade of inflammatory downstream events, you have to activate a molecule called C1q. And if you could block the activation of C1q, you could prevent recruitment of other immune cells, the attack by those immune cells, and damage to brain cells, what we call membrane damage. And what we see is that actually in patients with Huntington's disease, we have deposition of elements of the complement system on the synapses. That means the part that interacts between two brain cells. And these are elevated in patients who have Huntington's disease. If you look at the spinal fluid, which is a way that gives us a window into what's going on in the brain, we can see that there's elevated levels of activated complement. We can measure that by looking at a component of the complement system called C4A. As well, there is, accompanying this, evidence of ongoing brain cell loss, and that we can measure by looking at a compound called neurofilament light. So when you have more activated complement, you often have more brain cell damage and higher levels of NFL. And so if you block complement, you might be able to reduce the loss of brain cells, reduce NFL levels, and slow the progression of Huntington's disease. And that's the concept. And indeed, if you do this in animal models of Huntington's disease, there is evidence to suggest that you could slow the progression of Huntington's disease. So that's exactly what we tried doing in an open label study that we conducted this past year, in which we took 24 individuals who had Huntington's disease. We had about half the individuals in this trial in the United States were at our site. And so every 2 weeks, these individuals received infusions of this medication to see if we could slow the progression of Huntington's disease. And these people had very early Huntington's disease. Either they had recently developed symptoms or they were very close to the age at which we expected them to start developing symptoms based on their CAG repeat length. And we looked at blood markers and spinal fluid markers of complement activation, as well as we looked at the neurofilament light levels, as well as we measured the progression of Huntington's disease by examining the patient, looking at what we call the UHDRS. What we found is that when we gave them this medication, which blocks complement, we found that there was a reduction in downstream measures of complement activation, especially activation of the C3 component, which comes after C1, 1, 2, 3, 4, like that. And especially reduction in the activated level of C3 suggests that, in fact, we're reducing inflammation in the brain. And if we looked at the individuals at baseline, we looked at the amount of activated complement measured by the ratio of activated complement C4A compared to unactivated complement C4, about half our patients had a high level and half had a lower level of activated complement if we just split them in the middle. And if we looked at the effect of the medication, we found that people in green, okay, who had the higher level of activated complement at the baseline, they actually had an improvement. Okay, whereas the patients in blue, those ones who have lower levels of activated complement at baseline over the course of this study, they remained stable or slightly worsened. And inconsistent with what we see in the natural history study, measured in a study like the Enroll study, but done in Europe called the TRACK HD. So we had an observational cohort as a comparison because we had no placebo-treated patients in our group. And so basically we found that during the course of the treatment, those people who had high levels of activated complement remained stable or improved. Those people who had low levels did not really benefit from the therapy. And we saw that there was a differentiation between the two groups that was statistically significant. So because we see that there seems to be excellent evidence of what we call target engagement, being able to knock down complement, and we can see that there's a difference with individuals of high level of baseline complement, suggesting that the therapy may be effective in improving and slowing the progression of Huntington's disease. We're in the planning phase of doing a large phase 3 double-blind placebo-controlled trial that's likely going to begin this spring or this summer, probably enrolling about 300 patients globally. And we will likely be a site for that study. And we'll have most of the patients will need to undergo, everyone will need to go undergo serial spinal fluid testing, looking at the levels of complement activation and the efficacy of the drug therapy. And most patients will need to have a high level of baseline complement, as we've seen, because those seem to be the responder individuals. Now, we recently conducted a trial called the PROOF-HD study, looking at the effect of a novel molecule called perdopidine. We've done many studies in patients with Huntington's disease of this promising compound. This compound activates a receptor, a protein in the brain called sigma-1. Now, sigma-1, when activated, is a response to stress. And if you activate sigma-1, that seems good. It seems to protect brain cells. Why? Well, it reduces their degeneration. It improves their ability to produce energy to prevent degeneration, helps them clear toxic proteins, what we call autophagy. It improves the way in which the brain cells communicate, and it reduces brain inflammation. And in previous trials of perdopidine, what we saw was that patients who had early Huntington's disease, when given the medication compared to placebo, seemed to have slower worsening of their day-to-day function, and their NFL levels, gain a measure of brain cell death, seemed to remain stable rather than increase. So that was promising in the previous studies. So we did a very large-scale global double-blind placebo-controlled study in patients who had early symptomatic Huntington's disease to see if this medication would slow functional decline, measured by the simple scale called the total functional capacity score, in which you ask, can you work? Can you manage your finances? Can you do your household chores, etc.? And so we looked at whether or not perdopidine in the study would be helpful. Unfortunately, if we look at the overall large population of patients, we did not see a difference in the functional decline in those receiving the study medication compared to placebo over about a year. However, if we look at a subgroup of individuals who had the earliest HD, and we're not on any medicines for chorea, we're not on any medicines to improve mood, those patients seem to do better. In fact, seem to have slowing of progression and seem to have slowing of not only functional progression measured by the UHDRS, but also reduction in progression of motor function. We use quantitative computer-based scores of hand function as well as foot function compared to those people receiving placebo. So these results just came out about 2 or 3 months ago. The open label study is continuing, but that study will terminate in a couple of months from now. And so the sponsor, which is called Prelenia, is looking at whether or not further studies should be done in this compound with a subgroup of individuals with very early Huntington who are not taking any medicines. Now, as you all know, the triad of Huntington symptoms includes motor problems, often mood or psychiatric problems, and importantly, cognitive problems. And in time, cognition can be very much affected and affect day-to-day function. We call that dementia. And we'd like to have some medicine that we know will work to improve memory and thinking in patients with Huntington disease. So we are studying a very novel compound called SAGE-718. This compound in preliminary studies seems to be effective in many causes of cognitive dysfunction and actually has preliminary evidence of being effective in even Alzheimer's disease. Now, this medication works on a specific signaling pathway called glutamate. Glutamate is a brain chemical that's excitatory, and it acts on a receptor for glutamate called NMDA. Now, this compound is similar to a native molecule called 24-hydroxycholesterol, and 24-hydroxycholesterol binds onto the NMDA receptor to increase the activation of the receptor when glutamate binds the NMDA receptor. So SAGE-718 acts like a native compound called 24-hydroxycholesterol, and then as a result of increasing activation of the glutamate receptor, the NMDA receptor, we see that this may have beneficial effects on memory and thinking, and even improve behavior. So with this exciting preliminary data in various forms of dementia, we are studying it in patients who have Huntington disease, who have mild cognitive difficulties, or mild dementia. And so we're doing a study called the Dimension study, in which patients will have a 3-month double-blind placebo-controlled exposure to this medication. And then once they've completed the study, they can get long-term open-label access with no placebo. I will say anecdotally, we have had about 8 or 10 patients in the trial, and most of them anecdotally look like they are better in the open-label study. So we shall see once we have the full data analysis from the double-blind, but we are still enrolling patients who have early Huntington disease, who have mild cognitive difficulties. They do not have to have dementia. They have to have mild cognitive difficulties. Now, most patients who have been previously exposed to gene therapies like tominersen have been excluded from other clinical trials. What's nice is that we're just about to start another trial of this compound called SAGE-718, called the Surveyor study, in which individuals who have been previously exposed to tominersen, as well as others who have early Huntington who have not been exposed to tominersen, can participate. And this is a very short double-blind placebo-controlled trial, only for 4 weeks. And then they can get open-label drugs, so we can see how it's working. It's nice. And in fact, we're also going to be enrolling patients who, family members, who to serve as control subjects, who we match based on age, sex, and education to the individuals participating in the study. And it's pretty interesting because we're going to be measuring cognitive function, not by just doing the usual memory and thinking tests, but even we actually have a special driving simulator to look at cognitive responses and motor responses to driving simulated conditions. And it's a pretty interesting big computer system that we're going to be using to assess function, both in the control subjects and in patients with Huntington who are still driving. I'd like to briefly mention a trial that's in planning. It's being done by a company called Asclepios Bios. It's hard to say, that's what we call it, AskBio. And I've already talked about cholesterol a little bit. Now, we know, interestingly, that cholesterol metabolism is messed up, believe it or not, in brain cells in patients with Huntington disease. And so if you could restore normal cholesterol function by putting in a gene for this enzyme called 24-hydroxylase, that could improve the rate in which cells die and could slow the progression of Huntington's disease. And this aberrant cholesterol metabolism seems to occur because of the mutant Huntington protein that Dr. Forbes spoke about earlier. So there's going to be a phase 1/2 study of a viral therapy like you saw in the Unicure therapy, where we're knocking down mutant Huntington, but in this case, we're inserting a gene for 24-hydroxylase to try to slow the progression of Huntington's disease. This study is likely going to begin in the second half of next year. And it's a surgical study in which we inject the viral vector into the brain to insert this gene. So lastly, I'd like to briefly mention a drug that was recently approved for treatment of Huntington-associated chorea. We participated in the CONNECT-HD study of valbenazine. Valbenazine is what we call a VMAT, or vesicle monoamine transporter type 2 inhibitor. So when you give medications that are VMAT2 inhibitors, which include valbenazine, tetrabenazine, and deutetrabenazine, which is marketed as Austedo, you deplete dopamine. Okay, excess dopamine release in the Huntington brain causes chorea. So if you can reduce dopamine release, you could reduce chorea, and that's exactly what this medication does. And it works in the same way as the 2 other approved medications for Huntington chorea, tetrabenazine, deutetrabenazine. It has similar side effects such as sleepiness and fatigue, but generally tends to be well tolerated. And we can see, if we compare chorea scores, in blue we have the placebo group, in reddish purple we have the treatment group, and we can see starting by about week 2, when you're titrating up the medication, we see a separation from placebo, and we see a moderate but important improvement in chorea once you get to the stabilized doses for patients. So this is a valuable new addition to our armamentarium to treat troublesome chorea for patients with Huntington's disease. Now, Dr. Forbes mentioned the importance of observational studies. I would encourage all of you to consider participating in the Enroll-HD study. We are a site, we're one of the largest sites in the world for the Enroll-HD study, and it's a very simple study. It doesn't involve any medicine. It involves taking about 2 hours of your time once per year. And individuals who are affected by Huntington, individuals who are at risk of Huntington, whether or not they're gene tested or not, people who are gene positive, people who have been tested and been gene negative, and even family members who are control subjects can participate in the study. And what we do is we talk to you, we take a little history about how you're doing, we do a motor examination, we do some memory and thinking tests, we give you some surveys, and then we do a blood test to look at biomarkers. And there now, I've got 16,000, but now more than 25,000 individuals worldwide are participating in the study. And the purpose of this study is to better understand how Huntington varies from person to person, how it progresses based on age, sex, degree of CAG repeat length, and also, extremely importantly, to develop biomarkers, okay, to allow us to assess the progression of Huntington disease. You've heard that we have a lot of interesting trials, but we have limited numbers of patients who've got Huntington. We need to speed up drug development because time is wasting. We need to find out therapies that will improve symptoms, but more importantly, slow or stop the progression of Huntington disease. These trials take a lot of patients and take a lot of time. We need to accelerate that. Well, if we have to wait for people to progress clinically and get worse, that's a shame because it takes a long time. And those people are waiting to get on the right therapy. So if we can develop some blood or spinal fluid markers of progression that are more sensitive and quicker to show us whether or not the treatment is working or not, that will be helpful. The Enroll-HD study is all about that. We're trying to develop better blood markers and spinal fluid markers of progression of disease. And in fact, a spin-off study called HD Clarity study, which we're doing, looks now not just the blood markers that we're looking at in Enroll, but also spinal fluid markers. So individuals who are in Enroll can also participate in the Clarity study, in which we do a spinal fluid test to help us better determine markers of disease progression. And remember, I mentioned that compound called NFL or neurofilament light. The fact that we know that neurofilament light worsens over time and is a marker of disease progression, that was discovered as a result of the Enroll and the Clarity studies. And in fact, that's now being used as a marker for many other diseases like multiple sclerosis and ALS, even Parkinson's disease, because of the work done in Huntington's disease, because it's shown to be a marker non-specifically of brain cell loss. So we can use it in many other brain therapies. So the work of volunteers who participate in these studies has allowed us to discover something that's a really important marker. We need more markers like that that are Huntington specific to allow us to advance the therapies more quickly. So I would encourage all of you to participate in the Enroll study. I would encourage all of you to consider, if you're participating in the Enroll study, to participate in the Clarity study. And the Clarity study involves a spinal fluid test. It's a pretty easy test. It takes about 30 minutes. We do it in the office. It involves taking them up, putting a small needle into between the bones of the spine to remove some spinal fluid. We do that under ultrasound guidance. It's generally extremely well tolerated. And the risks are mainly headache, and that risk is about 1%. It's a very well-tolerated procedure overall. And we hope that patients who participate in the initial lumbar puncture, where we take off spinal fluid, will now participate in serial testing, where we're looking at it yearly for about 4 years, so we can see what the progression of these biomarkers is over time. Again, so we can develop an observational cohort to compare it to individuals who are getting a new drug therapy for various biomarkers. So I mentioned about NFL, and NFL progresses from pre-symptomatic through symptomatic phases of Huntington's disease and increases as brain cell loss progresses. So that's a very nice marker, but we need better and more markers too. So hopefully myself, as well as Dr. Forbes, have been enough of a cheerleader to encourage you all to consider participating in observational and other trials of Huntington, because this is how we're going to lick Huntington's disease. And by participating in trial, you get a lot of care because we care about you. And we want to give you the best access to new therapies. It also is a real source of hope, I would say. And it's something that you can do to help not only yourself, but help others. So it's a very meaningful thing to do. So I would encourage you to speak to Dr. Forbes and myself about opportunities to participate in various clinical trials. And we've mentioned many of these trials, such as Enroll, Clarity, the SAGE-718 trial, the Unicure study gene therapy trial, the PTC trial, the HD generation trial. And we don't want funding or access to be a barrier. I mean, we have funding, we have travel funds, we have grants to help people who have trouble getting to our site. I mean, we can send car service even to pick up people who can't drive to come to our site all for free for many of these studies. So I'd encourage you to talk to us about that so we can help people who want to be involved to get involved. Our goal is not only to treat Huntington, our goal is not only to slow Huntington, but is to prevent Huntington. We need to move our therapies beyond where they are now so we can implement them long before symptoms begin, so we can prevent Huntington symptoms from ever happening. That's really the goal of all of our work through the years. So I thank you all for your attention. I would encourage you all at the breaks to go visit the tables in the back